Returning this week is Dr. Russell Samson to talk about abdominal aortic aneurysms. Hello, doctor.
Hello. Thanks for having me.
My pleasure. I'm glad you're here. This week, aneurysms.
Yes.
Now, we know that there are, I've heard of aneurysms in the brain, but where else can they take place?
So aneurysms are a weakening in a major artery. A major blood vessel carries oxygenated blood, and they balloon out. So ballooning of an artery is called an aneurysm. And they're prone to happen in the brain, but in other parts of the body. Now, they are different in the brain and in the other parts of the body. So if someone has a brain aneurysm, it doesn't mean they're going to have it anywhere else. Or if someone has an aneurysm somewhere else, doesn't mean they're going to have it in the brain. But there are one specific area which is very common to have, which a lot of people don't know about, and that's a bulging in the main artery as it goes from your heart, through your chest, through your abdomen towards your legs. And that artery is called the aorta. And anywhere along that artery can have an aneurysm. It's a big artery. I don't know if this shows up to the viewers, but it's at least as wide as this hole in my finger. That's how big this artery is.
So a silver dollar
It's
size?
like a hose pipe. It's like a big hose pipe.
Wow.
So you can imagine if you have one of these things that then bulges out and ultimately it breaks, rapid death is usually what ensues. So you do want to diagnose this before it happens.
And how can you diagnose that?
So when the aneurysm is in the abdomen, we do the same type of test that you do on a pregnant woman to look at the baby. We use an ultrasound, or you can do a CAT scan, which I think most people realize is just a fancy X-ray, and you'll find the aneurysm. The problem with aneurysms is they are completely asymptomatic. In other words, they cause no symptoms, no pain, no discomfort.
Well, that's it. So how do you catch it before it actually occurs?
So if it's in the abdomen, as I said, your medical doctor will always examine you and feel your tummy, and if they feel it, they'll get the test. But sometimes
there'll be a bulge of
but it
some
can be
sort.
Difficult to feel and difficult to see. So even and if you're a little bit heavy or you've got a little bit of a stomach that's developing, you may not be able to feel it. So generally your doctor will, if they think you're at risk, if you're over 60, usually a male, you're a smoker, have high blood pressure, bad diet, coronary disease, then you're at risk, and most doctors will then order this ultrasound. In fact, if you're in the Medicare age group and you're over 65, and you are a male over the age of 65, Medicare will pay for an ultrasound, whether you're at risk or not. If you're a woman, unfortunately, they still don't pay for that test, but we are trying to get them to pay for it at this stage.
And because it happens more frequently in men, or?
It happens more frequently in men, and the results of treatment in women are not quite as good. And I think the government is concerned that unnecessary treatment will result in overdiagnosis in women. But women get it just as much, and they're just at risk.
Now, when you say that you're asymptomatic, again, is it just basically taking care of yourself? I mean, how do you can you prevent aneurysms from developing?
You can't. You can't. I mean, you can watch your diet, you can watch your fats, but there's definitely a genetic tendency towards this. So if you have a family history of someone that had an aneurysm, or someone that died, over the age of 55 or 60 for an unknown reason with a sudden death, you should consider that you may be at risk for an aneurysm too. So we generally recommend people who are in their 60s, who you can't really feel what's going on in the abdomen, to get a sound wave test and see what's going on.
So are there different treatments?
There are.
Is it,
So the standard treatment for many years has been a very big operation where we actually open the abdomen under general anesthetic, cut out the aneurysm, and replace it with a tube made out of Dacron. And that's about a 6-day hospitalization. With certain risks, obviously a big operation. Over the last 15 to 20 years, we're replacing at least half of these procedures by actually inserting an artificial artery into the aneurysm through a puncture in the groin. So we call that an endograft, because we're actually putting a graft, which is an artificial artery, inside the aneurysm. That's why we use the word endo, which means inside. And that's there, the patient comes in the morning, and they usually go home the following day.
Now you mentioned replacing.
Yes.
So people who've had procedures done before, they need to come in and possibly have that taken out and a new?
Well, I think you misinterpreted me, but
Okay.
you came up with a very, very important thing.
Okay.
So we do this replacement of the aneurysm if there is an original aneurysm, either by cutting it out, as I said,
Right.
or putting this endograft in.
Okay.
When we do the surgical treatment, it's usually extremely long-lasting, and we do follow the patient, but it's not critical. But with this so-called endograft, which is increasingly what we've been doing for the last 20 years, it's absolutely imperative that those people get followed on a regular basis, because what we're finding out is some of the original grafts that we were using are starting to fail, and the aneurysms are coming back. In fact, the FDA just put out a statement that anybody that's had one of these grafts must be evaluated every 6 months. So if you have people out there now that have had these in place, they've had an endograft put in, please, pay attention, go back to see your doctor and make sure you're tested on a regular basis.
Okay. And of course, what can possibly happen if they
If
don't
they
follow
don't,
up?
then the aneurysm comes back and they're at risk for a rupture. Now, the good thing is we have very easy treatments to treat these potential problems that are happening. So, we can do it without major surgery in most cases, even as an outpatient. But we have to know about it in advance. So these are good treatments. I'm not saying that someone shouldn't have one of these so-called endografts. They are good treatments. But if you have one, make sure you stay with your doctor.
Okay. And follow up?
Follow on a regular basis, at least every
basis.
6 months.
Okay, great.
Yeah.
Thank you, Doctor.
Thank you.
And please tell our viewers again where we can go to find out more information about you.
Vascular surgeons, our group, veinsанdarteries.com.
Great. Thank you again for being here.
Thank you.
Thank you for tuning in to Aging Gracefully on Suncoast FYI. We'll return right after the break.